Welcome to Health Matters, a show about the health issues and interests facing our community. I'm your host, Gilda Kramer. I'm a Lower Merion Township Commissioner, and I chair the Board of Commissioners Health Committee. Today, we're going to be talking about COVID-19 and vaccines. My guests are Dr. Hilary Nelson, who chairs the Lower Merion Township Health Advisory Council. She is a faculty member at the University of Pennsylvania, where she directs the Master of Public Health program. Dr. Eddy Bresnitz is an internist and preventative medicine physician with extensive vaccine experience, including at Merck, where he was the executive director of adult vaccines, and in the New Jersey Department of Health, where he was previously deputy commissioner and state epidemiologist and medical advisor on the COVID-19 response. Dr. Bresnitz, what roles have vaccines historically played in conquering other diseases?
Well, good morning, and thanks for having me on the broadcast. Vaccines are one of the greatest developments for reducing disease and death in this country and the world over the last century. And I use the word conquering, but I like the word controlling, because there's really only one disease that we've truly conquered, and that's smallpox, where there hasn't been a documented case since I believe the early 1970s. All other diseases still exist in the world and certainly in the US, but in many cases there haven't been any reported incidences for some time. So we're talking mainly about the childhood diseases such as measles and mumps and rubella, that's German measles, and tetanus and polio and chickenpox and diphtheria and maybe a couple of others. And there are occasional cases in the US of one or the other of those diseases. We haven't had any polio that's been incident here and individuals have been vaccinated. And so those diseases have been well controlled, not just in the US, but worldwide as well. Influenza is probably one of the most common diseases we still experience. We'll hear more about it later on. We control that disease, but we certainly haven't eliminated it, and we're unlikely to do so anytime in the near future.
What role are the vaccines playing in combating COVID-19?
Well, vaccines are one tool in our toolkit for reducing the risk of infection and also the incidence of severe disease. As most people recall, when the pandemic first reared its ugly head back in the early winter of 2020, for all of 2020, the only tools that we had in our armamentarium was isolation, staying at home, avoiding crowds, masking, personal hygiene, and so on. And the disease incidence was somewhat controlled. It varied around the country. It went up and down. And then vaccines became available right at the end of 2020. And so now we're almost a year into the vaccination campaign. And the good news is that well over 150, maybe 200 million people have received even one dose vaccine, and many of millions have been fully vaccinated. There are 3 currently authorized or approved vaccines available in the US, and I'm talking mostly about the US right now. The rest of the world is different. And we continue to see an increase in vaccine coverage amongst adults and amongst teenagers. And in very short order, within the next 2 weeks, we're likely to have a vaccine available for vaccinating children between ages of 5 and 11. So very instrumental in controlling the pandemic most recently. But they're not independent of the other non-pharmaceutical interventions, such as staying away from people, masking, washing hands, and so
on. Are there any myths about the vaccines that are contributing to people's hesitancy to be vaccinated?
Well, there are many myths and also misinformation. I want to separate myths from misinformation. So what do I mean by misinformation? Well, some people are reluctant to get vaccinated because they think that the vaccines are going to cost something. And that's not true. All the vaccines have been purchased by the US government. They're free of charge to everybody. There is no cost to either getting the vaccine or the administration of the vaccine, although providers do get some compensation for the administration. So that's a misinformation. But there are many myths as well. So, for example, one common myth is that getting the vaccine is going to give you COVID-19. Actually, this is a common myth for things like influenza shots. Well, the COVID-19 vaccines, none of them actually contain live virus. And so you cannot get COVID-19 from the vaccine itself. Now, you can have common side effects that could be confused with actually getting disease, such as getting a fever, feeling achy, fatigue, soreness where you got injected, and so on. Those are common vaccine side effects. But you cannot get COVID-19 from any one of the authorized or licensed vaccine. Another myth is that had prevented, in particular, women from getting vaccinated has been a suggestion that it will cause infertility. And probably this derives from the fact that the most common of the three vaccines are what are called messenger RNA vaccines. And whereby the vaccine, when you get the vaccine, you get a little bit of genetic code that actually leads to production of protein that stimulates immunity. However, that messenger RNA is degraded very quickly, very soon after it enters the body, and it cannot invade the human cell and cause any DNA abnormalities. And so it can affect the individual themselves, nor if they're pregnant, can it actually infect the fetus. And that's important because, unfortunately, pregnant women get vaccinated. And we know that only about a third of pregnant women to date have been vaccinated. And we've seen over 100,000 cases of pregnant women who've gotten COVID-19, and a couple hundred deaths of pregnant women. And in some cases, they've lost their unborn child, or the children have been born prematurely. So, yeah.
I've been reading, in fact, that there may be some benefits to pregnant women being vaccinated, in the sense that the children are born with some antibodies to COVID-19. Have you seen that type of literature as well?
Yeah, I've seen that. I don't know how well it's been studied, to be honest, but it certainly makes sense. And we have some evidence from the use of other vaccines. For example, the whooping cough vaccine. In fact, when women, the recommendations from the CDC, the Centers for Control and Prevention, recommends that every pregnant woman should get a vaccine every time they're pregnant. And so there is some data to support that, because you cannot vaccinate. They have to wait a few months before they can actually, neonates have to wait a few months before they can get vaccinated. And currently, we don't have any COVID-19 vaccine approved for children under the age of 12. As I mentioned, very shortly, we'll probably have one of the vaccines available for those 5 to 11. But we won't see vaccine available for really young children until sometime next year, down to the age of probably 6 months. And I don't think that we'll ever see any COVID-19 vaccines for children younger than 6 months of age. And so vaccinating a pregnant woman where there was who will then produce antibodies, which can then be transferred to the fetus, and then the fetus is born, becomes a neonate, and they may have some protective antibody on board until they're eligible to get vaccinated.
So what is the latest information on the safety and efficacy of the vaccines?
Great question. And actually, that's another one of the myths. In fact, that there hasn't been these are experimental vaccines, the 3 that are available, and they haven't been tested enough. And that's just completely wrong. All the different vaccines that are now authorized and or approved in the United States, and those 3 vaccines are the Pfizer vaccine, Pfizer-BioNTech vaccine, the Moderna vaccine, both of which are the messenger RNA vaccines. And then we have the Johnson & Johnson or Janssen vaccine, which is an adenovirus vector vaccine, a different mechanism for vaccinating individuals to stimulate immunity. And all 3 of those vaccines have been studied in what are called phase 3 clinical trials, where they basically assess the safety and the efficacy and the immunogenicity of those vaccines to produce antibodies, neutralizing antibodies, to reduce the likelihood of infection and also severe disease. And all three of those vaccines have very extensive safety profiles. And as I mentioned earlier, or alluded to earlier, there have been, hundreds of millions of people who've now been vaccinated, not just in the US, but worldwide as well, with one or the other of these vaccines. And so we have an extensive post-authorization safety profile, or post-approval safety profile, which indicates that they're both safe and highly effective in preventing disease, either mild disease or severe disease.
Do you know when boosters of the different vaccines are recommended? Because I know everybody's very excited about boosters being available. When are they recommended for different people?
Yeah, well, I first want to separate boosters from an extra dose. So a couple of months ago, the Advisory Committee on Immunization Practices and the CDC, based on data from follow-on studies on immune-compromised patients, realized that maybe these individuals who have depressed immune systems, either because of disease or therapy or a combination of the two, many of them weren't mounting adequate immunologic responses. So they recommended that these individuals get a third dose, preferably of the same vaccine that they had, the third dose for the mRNA vaccine, and a second dose of the Johnson & Johnson vaccine, at least no less than 28 days after they got their last dose. And completed the series. So this is considered an additional dose in the series. For those individuals who are not immune compromised and are fully vaccinated, as defined by 2 doses for one of the mRNA vaccines or 1 dose of the J&J vaccine, there's now a recommendation that individuals can get any one of the 3 authorized vaccines no less than 6 months after their last dose, where they would be considered fully vaccinated. And in fact, I want to specifically say that in those cases, the individuals can get a different vaccine than what they were originally vaccinated in the prime series. And this is true for individuals 18 and over. The target populations are those really focused on 65 and over, those between 18 and 64 who may have some underlying disease that makes them more at risk. And also individuals who may be working in or being in settings where they may have a risk of exposure. As for the J&J vaccine, the recommendation is actually that they get it within 2 months of getting the first dose because of a variety of reasons. And in those cases, in those situations, it's considered a booster dose of a 1-dose series. It's very complicated. It's very complicated. There's a lot of different perms and cons about these extra doses. And I think it's going to be important for healthcare providers to really understand what doses that they need to be given. I should also add that the Moderna extra dose is half the strength of the original prime series, whereas the Pfizer dose is the same doses they got in the prime series as the J&J second dose is as well.
Sorry, I'm going to have to interrupt our conversation, but we do have to take a break. We'll be right back with more about COVID-19 and vaccines on Health Matters. Stay tuned. Back to Health Matters. I'm your host, Gilda Kramer. We're talking about COVID-19 and vaccines with Dr. Hilary Nelson and Dr. Eddy Bresnitz. Dr. Nelson, we've been talking about vaccines as a major way to combat COVID-19. What other layers of protection are there, and when should they be used?
Eddy, vaccines are amazing, and they're particularly effective at reducing hospitalizations and deaths from COVID-19. But one of the things that we do know is that people still can get COVID, even with vaccines. So we need to consider other ways of preventing transmission. In particular, in public health, we're always worried about the population level impacts and protecting the most vulnerable. And those are going to be the elderly and the very young, and those who have other conditions that may impact their ability to mount a really good immune response. So we want to think about how do we reduce the transmission of virus in general. Now, when we think about any virus, there's two things that are important to think about. The amount of viral load or the dose that people are being exposed to, and the amount of time or exposure that they have. So you want to think about reducing those two levels. With COVID-19, we know that the new SARS-CoV-2 variant, the Delta variant, has an increased viral load. So people who are infectious actually give out more virus. And in addition, the other thing about COVID-19 is that people are infectious before they have symptoms. So thinking about all of that, the public health approach to harm reduction is including a multi-pronged approach on top of vaccination. Initially, all we had was testing, and testing is great because at a population level, it tells you how much community transmission there is, and on an individual level can tell you whether or not you have COVID and are able to infect others. But there's two other very important mechanisms that we need to continue to be using, especially if transmission is very high. One is masking. Masking not only prevents you from being infected, but it also prevents you from infecting others should you have COVID-19 without symptoms and not realize it. And with Delta having such an increased amount of viral load, it's become even more important to make sure masks that are being worn are high quality. So moving from the cloth masks, which were initially recommended because of the scarcity of surgical and N95 masks, moving towards masks that are higher quality surgical or N95 level, especially if you're going to be in a situation where you are going to be exposed to a lot of virus potentially, or you're going to be somewhere for a long time. The other key thing about COVID-19 is that it is transmitted as an aerosol. And this is why ventilation is such an important part of the picture. And this is why outside is safer than inside, because outside with a lot of ventilation, the virus can be distributed quite well. So inside, you want to be in a place that has a very high quality HVAC system with high quality HEPA filters that is sort of filtering out any viral load that's in the air. For people, though, who can't be in places with an up-to-date HVAC system, there are other mechanisms that you could use. Certainly opening up windows, having fans on, but the CDC just published an MMWR report that showed the efficacy of portable air filtration units in decreasing the viral load in a situation where someone may be infected. And in fact, they found that the portable air filtration units, in addition to masks, were really effective at reducing transmission. So I think we need to continue to think about masking, to think about ventilation, and also to think about overall viral load when considering when to use these additional non-pharmaceutical interventions. Again, outside space, probably don't need a mask. Inside space with people whose vaccination status and whose COVID-19 status you don't know, you would probably want to be masked, especially if you were not sure about the ventilation in that room.
Dr. Bresnitz.
Yeah, if I could just add to that, I just want to, Hilary has really summarized it very nicely. But I will say that based on my experience over the last almost 2 years, is everybody has their own level of risk tolerance. And so even though people might practice all those different layered measures, some people are much more willing to sort of go out in the public domain, eat in a restaurant, fly on an airplane, and so on. And others who may also have been practicing this, or have practiced the same preventive measures, including getting vaccinated, are much less comfortable to do that. And so there's no right or wrong in terms of how people assess their risk tolerance. We just have to recognize that people have different levels of risk.
And Eddy, I think that's a good point. And it also comes down to people's individual medical history. Correct. And their family. and so who they might possibly expose. So absolutely, I was talking at a very broad population level, but individually, people have to make decisions based on their own personal risk tolerance, which can be very different for different people.
These days, the assessing what your individual risk is in any particular setting is not an easy task. One of the I mentioned earlier that one of the groups the CDC has recommended who should consider getting a booster shot, not should get it, but may consider getting booster shot, are those who are in settings where they may have, additional occupational or environmental exposures. But in some cases, it's actually quite difficult to ascertain whether you are in one of those settings or not. It's not very clear cut. At this point in time, frankly, the recommendations for booster is anybody who wants it and who's eligible can get it.
Dr. Nelson, coming back to something we talked about earlier, how important is it for people to get a flu shot this year?
Incredibly important. So we are very worried about a twindemic of COVID-19 and influenza. We had a very, very low influenza level last winter, presumably because most people were sheltering in place and wearing masks outside. It's important at multiple levels. One is because it's very hard to differentiate the symptoms initially between flu and COVID-19 without testing. We also want to make sure that we're not overburdening our hospitals, which is something we saw last winter. So we want to sort of keep the flu levels down. Interestingly, recent research is suggesting that influenza is also transmitted in a similar aerosol manner to COVID-19. So the additional layers of protection besides vaccination, which is absolutely critical, but the additional layers of protection of both masking in certain situations and increasing vaccination should probably help with the influenza endemic that we get every winter.
If I could add also that, first of all, Hilary mentioned that our hospitals were overwhelmed last year. They were overwhelmed with COVID-19, not with influenza. We had very, very little influenza last year for the simple reason that people were practicing all those non-pharmaceutical inventions like staying at home, not being in public, and so on. In years before COVID-19, hospitals every season were overwhelmed with influenza cases, both in the emergency department and hospitalization. We ducked that last year because of all the things we were doing to prevent COVID-19. We're concerned in the coming season that, in fact, we may actually now be burdened again with people who've not gotten vaccinated with the flu vaccine. And I should say that people, if they haven't been vaccinated with their COVID-19 vaccine or they're looking to get the booster and they haven't been yet vaccinated with influenza vaccine, they can get both at the same time. One in one arm, one in the other arm. There's no reason to visit their health provider, whether it's their personal physician or in a pharmacy, twice. They can get it bang, bang at the same time.
Well, since it's so difficult to tell flu from COVID and even colds from COVID at times, what should somebody do if they or a member of their family is sick?
While you're waiting to get tested, which I think is an important thing, you should be taking precautions to protect those around you. So wearing a mask in public and being careful that you are not putting yourself in a position where you're going to be infecting people outside of your household.
Well, the CDC guidance is a little bit nuanced in that the recommendation is whether you're fully vaccinated or partially vaccinated and what you should do. But if you do develop symptoms, and as Dr. Nelson mentioned, the symptoms are really overlap. These are respiratory pathogens and viruses. And they have very common symptoms and signs of fever, achiness, soreness, headache, and so on. The one common, maybe the one distinguishing factor is loss of taste or smell, which can happen with both, but is more common with COVID-19. But if you've been fully vaccinated and you develop symptoms, you should get tested. And if you've been fully vaccinated and exposed to somebody who has COVID-19, you probably should get tested too, but not immediately, maybe 3 to 5 days after the exposure. So when to get tested and who to get tested is a little bit complicated. But the bottom line is, if you've got symptoms, you cannot distinguish them, the two of them, and certainly you've been exposed, you should get tested for COVID-19 and influenza. There are panels now that can test for both.
That's all we have time for on this month's show. I want to thank my guests, Dr. Hilary Nelson and Dr. Eddy Bresnitz, for being here and helping us to understand the latest information about COVID-19 vaccines. I'm Gilda Kramer, and I'll see you next time on Health